this third day of the symposium. And I would like to start and begin by acknowledging the traditional owners of the land on which many of our colleagues meet today. I would also like to pay my respect to elders past and present. My name is Liga Kuksha. I'm acting as a TBNet chair for the last 3 years, and I'm really happy to see that many of our colleagues are participating in this symposium, and I'm really happy and to say thank you for inviting TBNet for this very, very interesting and important symposium. TBNet is quite unique organization held in Europe region. We are together people who are interested in TB science and education, and many of these fields of tuberculosis. And TBNet has actually 3 main directions. One is education, with attention to the young generation, and I'm thinking about also generation change, also paying attention to our colleagues who are working in the field to be updated, and also knowing all the newest developments on tuberculosis. So in this regard, we have TBNet Academy every spring, and the European Advanced Training course, which this year was held in Warsaw, but we are together with Karolinska University, Filha, and also KNCV, and next year it's supposed to be in Hague. So, and also the TBNet is very, very active in networking. Every year we are holding our TBNet annual meetings, and all of you are very, very welcome on 18th of November in Copenhagen in Serum Institute, and there is also a link, and thank you to my colleague Simone, who will be one of the next speakers. He put also website link where you can check the information. And also TBNet is active on the studies, and then also in our website you see the most recent studies done and also published. So and you saw in the day before yesterday that Christoph Lange was presenting. Anka also is present in this symposium, and one of the next speakers will be also Simone. Myself, I'm situated in Latvia. I'm pneumonologist working mainly with tuberculosis, and also working with mostly difficult diagnose and treat TB patients, and also work as a consultant in virtual medical consilium based on organized by European WHO office. So as for today, our meeting purpose is to discuss the way tuberculosis interacts with other conditions, and also highlight that we know at this moment, and also highlight upcoming research, and also help each other to exchange ideas. So, and I also introduce you to keep your microphones muted and post questions during the presentations in the chat, and there will be answered in the chat, or later in the question session, probably the chair can invite you to unmute your microphone and say in loud your question. So please remain on the panel discussions at the end of the day, and because the discussions very often bring us a lot of idea, and also can see our each other practices. So I wish you all very successful day, and pass to the next chair of the Syndemic session.
Thank you. And I just want to just express our excitement as well, Liga, about the collaboration and the openness to work together between our European, Australian, and Asia Pacific regional colleagues. It's something that we've been um, trying to foster over many years. But now that Michaela is based in Europe and in Munich, there's always been the goodwill, but it needed someone to provide the glue and to organize things that will give content to this. So it really is wonderful to see all of this come together. And I think the Syndemics focus is clearly crucially important at this point in time, and a really good way of broadening the network. So I'm Ben Murray. I'm the director of the Sydney Infectious Diseases Institute in Sydney. I also co-lead our Centre for Research Excellence in Tuberculosis with Greg Fox, but we are a whole host of investigators that's part of our CRE community. ACTnet was born from the CRE. We are all very closely connected, and many of the people speaking today and in the previous sessions, like Michaela, is part of our community, but Justin, who will be speaking later, Sasi, we are very proud of all the activity happening in the broader region, and so glad that people are now better connected with initiatives in Europe as well. So we're going to have 4 speakers in the session, each with 15 minutes, covering everything from HIV and TB through to air quality and silicosis and mental health. We will try and include one brief question maybe at the end of the talk, but we'll have questions at the very end as part of our panel if we have time left. So I'm going to give our speakers a warning probably 2 minutes before the end, and then just if you wrap up before then, it's good, then there's more time for questions. But without further delay, I'm going to hand over to Simone Tunesi, who's our first speaker. He's from the Universitaria d'Alessandria in Italy, but currently on holiday in Sardinia and still joining us. So thank you, Simone. It's wonderful to hear from you.
Thank you very much for a nice presentation. And I'm very happy and excited to be here, and would like to thank the organizers for the opportunity. I'm directly sharing my screen so we can start. I think you can see my presentation. Do you?
Yes, we can see. If you can just put it, that's great.
Okay, perfect. So thank you very much again. My name is Simone Tunesi, and as I said, I work in an infectious disease department in a hospital in Alessandria, in north of Italy. And today, we have a lot of things to say about TB and HIV co-infection, which is a really huge subject. So let's just move to the body of the presentation. TB and HIV, we know that are two diseases strictly related, because they both act against the immune system. And we know also that the TB diagnosis is based on immunological tests. We use TST, tuberculosis skin test, and Mantoux reaction. We use IGRAS, quantiferon, T-spot. Those are tests that use check our capability to respond to the TB infection by our immune system. And we know also that HIV treatment and monitoring has mainly one aim, that stop the CD4 count loss due to the viral infection. So treating one condition can impact definitely on the equilibrium between the two diseases and the host immune system. Just a couple of words about epidemiology, just to say that TB and the HIV mortality is generally slightly decreasing in the last years, with some exceptions related if we check data from WHO region. We know, for example, that in the Americas there was a high high increase of mortality. There was also in Western Pacific region, where nowadays, after COVID pandemic, like in the other part of the world, tuberculosis mortality is generally decreasing. But if we look at the specific country in the region, staying in the Western Pacific region, we can see that there are some differences between some countries. For example, China reports a decrease in mortality in generally TB and HIV or without HIV infection, while, for example, in other countries, like Australia or Indonesia, and Philippines and Japan, mortality seems to be increasing. So if we have to also to consider that country by country, the general population count affect these statistics. What about the diagnostic test? Briefly, tuberculosis skin test is generally affected by CD4 count. There are some studies that indicate that CD4 count has a major impact on the results that can be performed in HIV-infected patient, about the indicating the tuberculosis infection. But we also know that tuberculosis skin test positive patients are intrinsically at high risk of developing tuberculosis, irrespective of their actual CD4 count. And if we consider tuberculosis skin test negative patient infected by HIV, only the patient with less than 200 CD4 cell per milliliter, which is generally intended as the cutoff for a severe immunodepression, have an appreciable risk of developing the disease. So this test is not so related with the real immune situation about tuberculosis and HIV infection for the single patient. And therefore, the recommended test for the diagnosis of TB infection remain quantiferon. Mostly, the last technology that is of quantiferon that is a test that involves also the CD8 response, not only the CD4 response. CD4 are affected by CD4 drop is the main effect of HIV infection. So this quantiferon test recruits also the CD8 response, and therefore is as affected by the CD4 count drop in advanced AIDS stages. TB infection and HIV, there's not so many things to do. All data available indicates and recommend that the tuberculosis infection, latent infection, must be treated in people affected also by HIV infection once the active tuberculosis is screened and ruled out. So preventive treatment of tuberculosis is always recommended in adults with HIV infection, and irrespective of the degree of immunosuppression. Just an early HIV diagnosed patient or an AIDS patient, while the active tuberculosis is ruled out, diagnosis is ruled out, they need to have a TB preventive treatment. And what for active tuberculosis, for TB disease, what we use for the treatment? The treatment it's actually the same. For rifampicin susceptible tuberculosis, we use standard quadrotherapy for 2 months and the 4 months of isoniazid and rifampin. But we know that usually there are some interactions between HIV drugs and rifampin. We know rifampin is a major issue for interaction for a lot of drugs, included HIV drugs. For multi-drug-resistant tuberculosis, on the other hand, we know that there are a lot of new short regimens nowadays, like BPAL, for example. But if we look into the studies that allowed these new regimens, patients were enrolled regardless their HIV status. So we can use BPALM, but we need some real life data that we will arrive in the future, hopefully. Just two more words about rifampin and antiretroviral treatment. The regimen currently recommended is the backbone with the tenofovir, alphalamide, or desoproxil plus entrectinib or lamivudine, and dolutegravir, so an integrase inhibitor. This is a regimen that can be used also in patient not infected by tuberculosis. This is it's not the last regimen that are currently used in clinical practice, but it's acceptable also for a patient that is not affected by tuberculosis nowadays. But there is one caveat, that is that dolutegravir, the integrase inhibitor, due to rifampin interaction, must be used at double dose. And when we have to start the treatment, the antiretroviral treatment must be started as soon as possible, but within 2 weeks of initiating tuberculosis treatment, irrespective of CD4 count. This is the standard indication recommendation, but we will see some exceptions later. What next future is facing us? Probably, as I said, the dolutegravir must be used at double dose compared to the single dose used for non-TB infected, HIV infected patients. This leads to some major cost. There is an increased risk of adverse events, of course, that can lead also to a less adherence for the treatment. And there is this trial, interesting, that use dolutegravir double dose with dolutegravir plus, not another pill of dolutegravir, but a placebo. And this study seems to show that there is a similar HIV RNA suppression. The adherence is the same, and there is no selection of integrase inhibitors, so the pharmacological class of dolutegravir resistance. And in the next future, maybe we can also use some single tablet regimen, bictegravir based widely used anti-HIV drug. Theoretically can't be used in association with rifampin, but probably in the next future, these are some PK/PD studies that show that in the future we will be allowed to use the single tablet. This is, of course, will be super useful in the future because is slightly reducing the number of pills to be taken. Let's move to this phenomenon that is really specific, typical for HIV and TB co-infection, the immune reconstitution syndrome. IRIS. IRIS is reported in literature. There is a wide range of reporting, from 4 to 50% of cases of co-infections in case series. And there is a major risk factor. There are some major risk factors. So when we can expect the immune reconstitution syndrome, that is a super strong inflammatory reaction after TB and HIV treatment. When patient has a low CD4 count, less than 50 cells per microliter, so a very severe immune depression, and we don't know very much when to start the treatment in order to avoid IRIS, because if we consider the co-infection, the co-administration of the both treatment as categorical variables, so at day X and day Y, we know that in literature there are some discordant results, so studies are not so well comparable. And if we consider as continuative variables, so from the later we go on with weeks to start the both treatment, we just know that risk decreases as interval enlarges. So the more we enlarge the start of the second treatment, the more the risk is decreased. But we don't have some milestones definitely in literature. We know also that disseminated tuberculosis is a major risk factor, and the high viral load is a major risk factor to develop the immune reconstitution syndrome. Let's move to the pathogenesis. Why we have this phenomenon?
Say 3 minutes. 3 minutes.
Yes, almost done. When we have a mycobacterial tuberculosis infection, mycobacterial tuberculosis accumulate in the macrophage, and accumulating in macrophage there is not the answer from the CD4, the help for the CD4 due to the CD4 because they are dropped because of HIV infection. But then we start the antiretroviral therapy. The antiretroviral therapy lead to a CD4 increase. So there is a massive release of interferon, gamma interferon. And then what's happening? That macrophage are attacked by interferon, gamma interferon, and then there is all the inflammasome activation. We don't need to see every single molecule and transmitter. And then after inflammasome activation, we have a neutrophil recruitment and activation that lead to this tissue damage. So there is an accumulation of mycobacteria due to the energy of the immune system, and then the antiretroviral treatment switch on the immune system, leading to the iris pathogenesis. The treatment for the iris is no treatment at all for mild iris, and steroids at high dose, 1.5 milligram kilo day for 4 weeks for the severe infection. And there are some case series about the use of anti-TNF. No, but there are not randomized clinical trial. Couple of words about TB meningitis. TB meningitis lead to a higher risk of iris, and there is a high reported mortality for this phenomenon, up to 53% of cases, and mostly sequelae. Iris has to be considered when there is a worsening, a clinical worsening of the patient under antiretroviral treatment. And we don't have to forget that AIDS means syndrome. The S of AIDS is syndrome. So we have to rule out all the other causes of meningitis, Cryptococcus, Toxoplasma, BK virus, cytomegalo. And we have to start, in this case, ART after 8 weeks of TB treatment in order to reduce the risk of iris. And in general, in person with less than 50 cells per 50 CD4 per milliliter, ART shall be started within the first 2 weeks after the initiation of TB treatment, because this is considered a more severe condition. And in all other cases, ART should be delayed 4 weeks in other cases in order to avoid the immune reconstitution syndrome. And there is an general indication to treat the iris, of course, they treat with corticosteroids as iris, and in a prevention, if we want to prevent the iris, there is a suggestion to delay of 8 weeks the antiretroviral treatment start in order to reduce the risk of meningitis in the most severe and immunocompromised patient. Okay, I think I'm done. I would like to thank you for your attention. This is a nice picture from the last TBNet Academy. As Liga said, I will renovate her invitation to join our community in TBNet, because I think that it can be a major opportunity for people interested in tuberculosis to find a community of colleagues which we can confront, compare, and participate in a lot of educational events. And I would like to thank again the organizer for this opportunity. Thank you very much.
Thank you, Simone. Just one quick question, which I think came from Jabal Foster. Is the understanding correct that when a CD4 count is not available, ART should always be started as soon as possible after TB treatment start? It's only in TBM where there's an 8-week delay that's advocated. But in all other instances, irrespective of CD4 count, you start as soon as possible. Is that?
Yeah. Generally, this is the indication. You just have to consider that. Sorry, I couldn't find the button for stop sharing. You just have to consider that sometimes in those cases, the treatment can be worse than the infection, because there is this equilibrium between the immune system that has been damaged by the HIV infection and also by the tuberculosis, and the two infections. So moving this equilibrium actually can lead to major damage. And therefore, if you can, for clinical, if the real aspect, the real clinical situation of the patients allows you, you can, the more you delay in the most severe immunocompromised patient, the starting of the second treatment, the more you reduce the risk of developing the iris. Sometimes it's not so easy to do this. Sometimes it's not so easy to give also so many immunodepressant drugs in an already immunodepressant patient, but finding the equilibrium between those two needs is the key to manage this patient, mostly in the early phases of treatment.
Thank you. I'm going to ask if you don't mind to maybe also address questions in the chat. Then we can move on to the next speaker, which is Mimi Malhotra. Mimi is at the Liverpool School of Tropical Medicine in the UK. And I just want to check if Mimi is ready to share her screen.
Yeah, just sharing now. Thanks so much.
Wonderful. Thank you.
You see that?
Yes, we can see you.
Great. Perfect. Good morning, good afternoon, everyone. I know we're covering lots of different time zones. It's really great to be here and echoing everyone's thank you to Michaela for bringing us all together for this fabulous 3 days. So as Ben mentioned, I'm a PhD student currently at the Liverpool School of Tropical Medicine, but actually based in Zimbabwe, and I'm a respiratory physician by background from the UK. So I'll be talking us through TB and silicosis. So to start with, just to orientate ourselves so we're all on the same page, I wanted to start on silica and silicosis. So crystalline silica is a naturally occurring mineral that's found in the Earth's crust, and second to oxygen is one of the most abundant minerals. It's also the main constitution of many rocks. And respirable crystalline silica, commonly called silica dust or RCS, is largely, I guess, in the atmosphere and air through occupational risk factors such as mining, quarrying, and sandblasting. And the particles that are released are usually less than 5 micrometers in diameter, and these then have the capability to reach distal airways and alveoli. And this, due to some mechanistic interaction, can cause silicosis, which is the incurable and progressive lung disease caused by silica dust. And this is characterized by a fibrotic and sometimes emphysematous picture within the lungs. As I mentioned, it's incurable, but the palliative treatments on offer tend to be oxygen and pulmonary rehab. So literature describes associations between silica exposure and lung infections, including TB, which we'll talk about later, non-tuberculous mycobacteria, fungal infections, lung cancers, and then also kidney and rheumatic disorders as well. So historically, the gold standard diagnostic test for silicosis was at post-mortem, which is largely unhelpful if you're a clinician trying to diagnose it with the participant or patient in front of you. In practice, even today, clinicians are having to rely on a combination of exposure history, imaging, and exclusion of other diagnoses. And that makes estimating the global burden quite difficult. However, as part of the global burden of disease data from 2023, we think that there are over 140,000 new incident cases each year and over 15,000 deaths from silicosis each year based on what's reported. And apologies, I know this figure is quite small, but from the red line, you can see that over the past 20 years, prevalence does seem to be increasing again. And this is largely driven by high and middle income developing countries. This graph here highlights that the rising in prevalence is particularly driven in countries such as China, South Asia, those within Southern Africa and Brazil, and that's largely attributable to occupational mining and stone cutting. However, just to highlight, silicosis is also re-emerging in high-income countries, including the US, Australia, and the UK. And I've just put some screenshots of newspaper articles here, which have really highlighted the re-emerging issue in these countries as well. So the association between silica dust and TB is not new and dates back to over a century. Here's a quote from a paper published in the 1960s and a figure which shows that the percentage of cells with TB bacilli starkly increased with exposure to silica dust. But much of the early studies and experiments, which were largely done in rat and animal models, looked at silica exposure and TB to try and determine disease phenotype and what should be treated first, or what the focus could be. I don't expect everyone to kind of learn and memorize this, but the earlier data definitely tried to come up with that chronology, whether the silicosis happened and then the TB, or the dust exposure and then the TB, whether it was historical TB and silicosis now, or whether there was this burn burnt out query treated TB, which then on top of that had silica exposure. So there's this huge wealth of data that was generated through these studies in the 1950s and 1960s, but largely after that with the introduction of anti-tubercular therapy and also changes to industry regulations in coal mining. For example, in South Africa, miners that then developed TB were no longer able to work in the mines. It seems to have fallen off the research agenda. And this was without us actually understanding why the two conditions were mechanistically intertwined and why the risk of each kind of posed to each of them, outside of course, the social influences. So one of the landmark meta-analyses in this field from 2021 aimed to quantify this risk or association in response to the kind of emerging epidemics. And here you can see an almost twofold increase in TB amongst those exposed to silica dust. When we look at silicosis itself, so radiological silicosis, not just the exposure to silica dust, this risk of TB increased to fourfold. And there was no real difference between whether this was in a high or low burden TB country at the time. The same systematic review and meta-analysis also sought to describe the association between silicosis severity, and this was using the International Labour Organization grading and TB, and it showed a clear association, which hopefully you can appreciate, that with increased silicosis severity, there was increased risk of TB. I guess just to flag here that radiological silicosis is thought only to be apparent in 45% of patients with silicosis, and severity on chest X-ray or CT scan does not always correlate to the clinical picture or disease manifestation intracellularly. Anecdotally, individuals with silica exposure are more likely to have severe TB, die from TB, and have recurrent TB, but there isn't much evidence on this that's published in the literature. An unpublished meta-analysis from one of my PhD supervisors has identified these 4 studies, 3 of which are quite recent, from Zimbabwe, China, and India, which definitely shows a signal between the association of poor TB treatment outcomes and silicosis. However, the kind of endpoint or the treatment failure was different between each of the studies, which is hopefully something that can be addressed in future studies. So where are we now? In preparation for my own PhD and for this talk, I found it quite helpful to try and break up the associations for silica exposure, that subradiological silicosis, which can affect over half of those with actual silicosis, and then the radiological silicosis apparent on either chest X-ray or CT scan, against important elements of TB disease, so including prevalence, which we've discussed briefly, TB severity, the TB treatment outcomes, potentially with a particular focus on recurrence and mortality, because we know this isn't really understood, post-TB lung disease, which everyone is beginning to talk about in this field, including in the occupational literature, which is really reassuring, response to BCG vaccination, TB infection, and also TB preventive therapy. So I've presented some of the literature from prevalence for both silica exposure and radiological TB, as well as severity and treatment outcomes, but you can see that there are still gaps, at least in the clinical phenotypes for this. I guess also anecdotally, we know that lots of people are retreated for TB, especially if they have occupational exposure to silica dust, but we're unsure whether or not this is true TB or not. And I guess in the context of a high TB burden setting, a low healthcare resource setting where you know silicosis is incurable, but TB is potentially treatable, then you would treat for TB again. Work on BCG response has been quite limited since the 1950s, with regards to TB preventive therapy, we know that there was this big trial in South Africa, the Thibela randomized control trial, which showed some short-term efficacy within the first 12 to 18 months post-treatment. I also just wanted to say here that in an era where the WHO and others are recommending shortening TB treatment regimes, those exposed to silica dust or with silicosis have largely been excluded from those studies or trials, and that presents a real risk for this population, who we think probably have worse TB treatment outcomes on existing regimens anyway. So broadening these concepts out, this DAG published in a paper by Howlett et al. This year, I think really nicely incorporates some of the other structural and social determinants that likely influence populations at risk of both TB and silicosis. This includes smoking, poverty, overcrowding, malnutrition, and HIV, which I know have been covered in the symposium in their own right. A group particularly vulnerable to these social risk factors and exposed both to TB and silica dust are miners, and in particular gold miners and those working informally. My research looks at this group of artisanal and small-scale miners in Zimbabwe, where there's an estimated 500,000 informal miners and over 2 million, or 1 in 8 of our population, dependent on it. And it's a large and growing industry here due to the large reserves of lithium and gold, and also the significant impact it's having on GDP with the exportation of these minerals. Work from a 5-year USAID-funded project led by Professor Moyo highlighted a triple burden of disease here in this context, with TB, previous TB, HIV, and silicosis being highly prevalent. And very briefly, my PhD hopes to build on this through a prospective longitudinal cohort of these informal miners, the artisanal small-scale miners, with and without TB, and comparing their lung health outcomes over a period of time. And one of the additional elements is to try and see what the role of computer-aided detection in TB diagnosis within this population is. As we all know, the WHO has encourage the role of CAD in these high burden settings, but again, we don't really know what impact this has on those with radiological change secondary to other conditions such as silica exposure. So thank you so much. Naturally welcome any questions or comments.
Thank you, Mimi, for keeping the time. And I just want to see if maybe if there's any questions. I can't see any on the chat at this point. Michaela, I see you. You have a question. If you want to ask that yourself, just feel free.
All right, thanks, Ben. Thank you so much for that, Mimi. This is probably a bit of a niche question, but I was just curious as to whether or not the silica dust could potentially be acting as a fomite to kind of keep TB in the infected air spaces in a mine, even after there's no kind of person-to-person active transmission, if that could enable it to thrive in the physical environment for later infection if re-aerosolized. Thank you.
Yeah, thanks, Michaela. That's a really interesting question. I think some of the earlier studies did actually try and look at that in animal models and were slightly inconclusive. I guess what we know now, which might make it quite difficult to explore, is some of these informal miners stay underground for 6 months at a time. So they're not really having any form of, yeah, I can see the shock on your face. That was what I thought as well when I first heard. So there isn't really much ventilation underground or air circulation. And then how would you remove that kind of person-to-person transmission, particularly when we know that the informal miners aren't really using any form of protection, which I guess is a whole separate issue in itself. They don't want to be identifiable because in some of these contexts, it then means that the formal mines can see where there's minerals and kind of take the land out from them, but also from a funding and resource perspective, it's not something that's prioritized. I think something that I didn't cover, which is important from a social perspective, is that there's also so much misinformation within this occupational group. So here in Zimbabwe, it's commonly thought that if you drink milk, then you can't get TB, you can't get silicosis, and that will kind of resolve your lung symptoms. So not a direct answer to your question, but definitely was something that was hypothesized and considered in the 1950s. And it's just a shame that that kind of dropped off the research agenda. But thank you.
Thank you.
Thank you, Mimi. It's just amazing to think that we've had contributions from Sardinia and from Zimbabwe, from the coalface, and clearly the plight of these small-scale artisanal miners is something that needs far greater scrutiny. It's a growing group in South Africa, in places like Myanmar, and these are common challenges that you are describing, which are often occurring in very marginalized people. So thank you for making us aware. I'm going to ask Claire Calderwood to speak to us on TB and mental health, which will bring a whole new different angle to this, but it will probably tap into the same complexity of overlying factors as both Mimi and Simone highlighted.
Hi, everybody, and thank you very much again to Michaela and to everybody. It's been a fascinating 3 days, and I've learned a huge amount, and it's been really important to bring people together on this important topic. So I was asked to speak about TB and mental health as part of this symposium, but I think that I wanted to start, if I can change my slides, by actually saying that I think that probably in our discussions about TB syndemics over the last few days, actually, I think perhaps we should think that mental health and TB is its own syndemic, but actually is a component of all of the different syndemics that we have been talking about. Given how common it is, and also how mental health is associated with many of the other different factors that we've talked about over the last 3 days as being important in driving TB syndemics. So by way of background, and if I don't need to convince you that mental health is important, mental health disorders are the leading causes of years lived with disability globally, outside of anything to do with TB. We know that mental health disorders are extremely common among people with TB, and as well as a sort of bidirectional relationship that we talk about a lot of things, there's perhaps even a vicious cycle and a sort of a circular process that happens between TB and mental health disorders, with TB being driven by poor mental health, as well as TB driving further poor mental health among people who are affected with the disease. We know that among people who have mental health disorders at the time of their TB diagnosis, there is double the risk of poor treatment outcomes compared to people who do not have mental health disorders. So just to summarize some of the literature on this, and I've kind of gone for a very broad overview, given there's quite a lot of studies on this topic, and pulled out 3 systematic reviews here. It says my internet connection is unstable, so I'm just going to turn my video off. Hopefully you can all hear me. Please shout if you can't. The first systematic review looked at the prevalence of depressive symptoms among people at TB diagnosis, identifying that 54% of people who were diagnosed with TB had symptoms of a depressive disorder. And when we look at other studies and that more broadly, that ranges massively from up to 84% of people being diagnosed as having a mental health problem based on screening at the time of TB diagnosis. Really importantly, another systematic review looked at the prevalence of suicidal ideation and suicide among people with TB, and identified 3 studies that had used verbal autopsy to look at cause of death among people with TB, finding that between 2.2 and 8.4% of deaths among people with TB are due to suicide. And then finally, the third systematic review that I highlighted here looked at whether there are interventions that have been developed to try and address TB and mental health, and that identified 11 studies of psychosocial interventions, which all improved TB treatment outcomes and reduced mental health symptoms. And I think this systematic review is really interesting when you sort of dive into a bit of the detail that's included, which I felt was going to take too long today, really thinking about how these interventions work. And I think that those, the themes that really came out of that really resonate with a lot of what I've heard talked about in the last few days about addressing stigma, about improving resilience, and about thinking about family-centered and community-centered care. And as a result of all of this evidence, this WHO handbook, which has recently come out, looking at TB and comorbidities, is specifically focused on mental health and people with TB. And this is the recommendation, which says that ideally everybody with TB should be assessed for mental health conditions or substance use disorders prior to or initiating treatment for TB. But as I'll come back to later, services are mostly not available, and this is a real and really important gap in thinking about TB and mental health. Cool. So as well as at TB diagnosis, mental health also appears to be important during the period of TB treatment and after TB treatment. And as Mimi also mentioned, increasing focus on the fact that what happens as TB syndemics doesn't end when the person finishes their TB treatment, but persists into the rest of their life. There are two studies that I've highlighted here. The first one on the left, sorry, I haven't included a reference, recently came out, and I'm happy to put it in the chat, but looked at depression and mental health related quality of life among people at their TB diagnosis at the end of their treatment in orange and 6 months after treatment completion in blue. And while symptoms of depression appeared to get quite a lot better based on the screening tool that this group used, it still seems that up to a third of people, up to a quarter of people 6 months after their TB treatment have impaired mental health related quality of life. And in my PhD in Zimbabwe, we also looked at this, and this is just a sort of a very brief snapshot of some of the data from that. And we looked at symptoms of common mental health disorder using an indigenously developed tool called the Scholar Symptom Questionnaire 6 months after people's TB treatment completion on average. Out of the 92 people we screened, 45% screened positive for common mental health disorder symptoms. And I think what I found really shocking when we were doing this work is that a quarter of people had red flags suggestive of severe mental illness. And in this tool, the red flags are essentially visual hallucinations or thinking about suicide. 33% of the people who participated in this screening said that their mental health was having a large impact on their day-to-day life, and therefore this is likely to be translating into impacts on function and impacts on ability to work and economically contribute to your family and to society. And I think also importantly, 93% of people who had mental health symptoms had not been screened or not been asked about their mental health during the period of their TB treatment. So despite the fact they'd been engaged in care for 6 months, no one had asked them about mental health. And I just wanted to come back to this a little bit, which was a big focus of my PhD, and I think some people have heard me talk about this before. And I think, again, this is something that's come up over the last couple of days. Knowing that TB is a disease of precarity, and TB does not affect people in isolation as an individual, it affects them as a member of their family and a member of their society. And that is driven by sort of large existential factors, mostly of which are outside people's control. In addition, the consequences of TB further drive this cycle of precarity. And if I sort of switch this lens around thinking about what drives poor mental health, all of these factors both cause and further exacerbate poor mental health, not only among individuals with TB, but also among families and communities. So we looked at mental health among members of TB-affected households. Here, I've just summarised some evidence from a literature review, which I did, looking at the prevalence of chronic conditions amongst members of TB-affected households, identifying 3 studies globally, which is very little literature that has looked at this. But what those studies have found is that between 13 and 47% of members of TB-affected households had symptoms of mental health disorders. And for the studies that looked at whether there was an excess risk compared to other members of the same communities, it appears as though people who live in TB-affected households are more likely to have symptoms of depression compared to other members of the same community. So TB is doing something to drive mental health at a household level. As again, we've also talked about, we know that family members play a critical role in supporting people with TB, and they share the burden of disease. And therefore, we need to think not only about supporting mental health for people with TB, but also about those people who are their critical treatment supporters. In Zimbabwe, I haven't presented a lot of our data, but we looked at mental health among people who are living in TB-affected households at the time of TB diagnosis and 6 months later. And we did see that there's some improvement, and there is sort of likely to be an element of this that is reactive affective symptoms responding to the existential stress that the TB episode has placed on a family. I'm not going to talk about this too much, but this was just one of the in-depth interviews where we looked at, where we talked to people about their mental health in TB-affected households. And this woman talked about how she essentially was kicked out of her house because of the stigma around the fact that there had been a TB diagnosis. And I also wanted to highlight this work from Collins, who we heard from yesterday, talking about social protection for people with TB, where we did workshops with adolescents and young people in Zimbabwe to think about what the impacts of TB were on adolescent well-being. And I think really, again, here, mental health comes out as a really important component of what it means for a young person to be able to thrive. And TB sort of completely disrupted and interrupted that ability to live up to your potential and to achieve your dreams. And therefore, this not only has an impact in the short term, but likely has a long-term impact on these young people's identities and their future productivity and future health. So finally, in the last couple of minutes, I thought I would talk about a couple of other things which are still related to mental health, but slightly more broad, drawing on a couple of themes that I've heard come up in the last couple of days. So this is a piece of work which I did with Michaela and other people on the call, including Ben, over the last couple of years, developing consensus on integration of TB care and TB screening in a global context. Just to say, we heard from a lot of people, many of whom I imagine might be on this call, on their opinions, and we're really grateful for all of the input which we received. The key messages that came out of this Delphi process were that we need to screen people with TB for relevant non-TB conditions, that we need to provide care for relevant non-TB conditions during the period of TB treatment, and those services should be integrated into the TB care services. And finally, the integrated community-wide screening. Community-wide screening should be integrated with other health screening and services. And I will put the link again for the preprint for this in the chat. But just to say, I completely acknowledge, and we've acknowledged from the sort of many opinions that we've heard, that this is a hugely challenging thing to do in practice. Finally, sorry, Ben, am I finished?
No, please wrap up. That's all good.
Finally, panelists reported that mental health services were only available in 16% of the 80 countries that we heard from as part of this survey, really then again demonstrating this huge gap in access to services. So it's not only enough that we screen for these conditions, we need to make sure that services are also available. And then finally, when we asked people to rank their top priorities for integration into TB screening and care services, mental health ranked 4th after HIV, diabetes, and nutrition. But here I really want to highlight that when we disaggregate our responses and we look at what people who had lived experience of TB had to say, mental health ranked 2nd above several of these other conditions, particularly in the household contact setting. So finally, to summarize, I think TB and mental health perhaps is not its own syndemic, but TB and mental health is at the center of multiple TB syndemics. We know that poor mental health is extremely common among people with TB and among family members, likely driven by the context and the effects of TB more widely on people and their families. There is some suggestion that these symptoms are perhaps reactive and are worse around the time of the TB diagnosis. But I think that it's important to say that that doesn't mean we should leave people to struggle with these symptoms during the period of TB treatment, just because we think that for some people they're going to get better. There's an urgent need to develop mental health services for people with TB. These should be accessible, they should address stigma, and they should consider the needs of the whole family. And I wanted to finish, just because this came up on Wednesday, with saying how we're thinking about perhaps addressing this TB syndemic. So Restore is a cluster randomized trial of a multi-morbidity intervention, which we're integrating into routine TB services in Zimbabwe, and includes support for smoking, nutrition, diabetes, mental health. We're really lucky to be doing it in collaboration with Friendship Bench, which is a scaled model of mental health services across all primary care clinics in Zimbabwe, as well as an adapted model of pulmonary rehab to try and address physical disability and chronic lung disease. So those are my acknowledgements, and thank you very much for the opportunity to speak.
Thank you, Claire. It's really a wonderful overview, and also reminding us that there are some really positive interventions like the Friendship Bench that are feasible and scalable, and hopefully we'll have more data on that soon. I just want to ask you, coming from South Africa, and having met Desmond Tutu Mandela. It was interesting how both of them had TB. Both of them often referred to their TB experience as something that greatly increased their resolve and their mental resilience. And I'm just wondering, it's a slightly left field question, but has anyone looked, or have you ever had an interest at looking at those patients who maybe increase their mental resilience after such a difficult period in their lives? And what can we learn from them?
Yeah, I think that's a really interesting and important question. The first thing to say is that the studies that have looked at mental health after TB treatment essentially are fairly limited and are limited to, we did some mental health scores and we've described the prevalence of mental health symptoms among people after TB treatment. I'm not aware of any qualitative literature that has sought to follow people up long term after TB and think about their mental health and how that has changed over time. But as you say, yeah, you could imagine a perhaps subset of the population where you feel if you've survived this, you could survive anything, given how distressing the TB episode itself was.
Yeah. So not diminishing the need at all, but just saying that it's an angle to consider as we develop this area.
I think it'd be really interesting to get people to look back at it with a sort of a historic perspective and how they feel now.
Yeah. Thank you. Just to say, if people have questions, if you could just put that in the chat so we can come back to some of them if we have time. But I'm going to move on next. Thanks, Claire, to Rujan Venter from Stellenbosch University. And I assume you're talking or speaking from Cape Town, Rujan, but Rujan, over to you.
Ben, yes, I'm actually, let me just get my video working. I'm actually in Stellenbosch at the moment. I got my dates, or we got the dates mixed up. So I'm at another conference as well. So I will leave shortly after this. Let me just make sure my screen is, can you see my screen?
Yes, that's excellent. Thank you.
Okay, great. Okay, so good morning, everyone, or afternoon or evening. I'm Rujan Venter. I'm a researcher based at the Clinical Mycobacteriology and Epidemiology Group at Stellenbosch University in South Africa, which is headed by Prof. Grant Ron, who is unfortunately or fortunately in Mali at the moment. So I'm presenting on his behalf today. And I'll be presenting on air quality as a driver for TB syndemics. So my research focuses largely on TB, understanding TB infectiousness and transmission, specifically by doing aerosol sampling. And most of you know, of course, TB is transmitted by airborne infectious aerosols, which are less than 5 micrometers. And these can stay suspended in the air for prolonged periods of times and can also travel long distances in the air. And so when these particles are inhaled by a susceptible host, that's when transmission occurs. Important to note is recent research has also shown that about 50% of TB is actually asymptomatic. So using TB symptoms as a kind of indicator to triage people for further testing is maybe not ideal. And this is why TB continues to be transmitted and become a problem. Not become a problem, remains a problem. It has, as you've known, reclaimed its #1 spot as the cause of death from a single infectious agent. And as this is a respiratory disease and is transmitted via aerosols, one can think, of course, that air quality plays a huge impact on this. And air pollution in its own right is ranked as the 4th largest risk factor for global mortality. So you can imagine these two together are not great. So in terms of air quality and pollution, this of course leads to lung inflammation, reduced immunity, and a higher risk of TB reactivation. And there are several elements that contribute towards this. The most commonly cited is the particulate matter. So these are small particles that are smaller than 10 or 2.5 micrometers in size. There are other ones, of course, but these are the most commonly found as a risk for increased TB incidence and progression. There's also studies showing that long-term exposure, specifically to PM2.5, leads to an increase in TB mortality. Then, of course, we've also got the gases. So we've got nitrogen dioxide and carbon monoxide, which have also both been quite extensively linked to increase of TB risk. Sulfur dioxide has also been reported in several studies. There's evidence showing that there might be some protection for drug-resistant TB, although the evidence for this is limited and needs to be substantiated some more. Oh my gosh, what have I done? So sorry. There we go. Okay, and then ozone has also been mentioned in several research studies, but the results are that it's got a limited effect, but there's emerging research showing links to drug-resistant TB as well. So other than these factors that influence these elements that contribute towards pollution and poor air quality, there's also other factors that come into play. And again, these have been mentioned by previous talks. Temperature variability has been shown to trigger an increase in TB admissions. With a bit of a lag. There's also, of course, humidity and UV radiation that has been linked to transmission. So if you think about someone with TB that has coughed or is breathing, those small particles that stay suspended in the air are the ones that are most likely to cause disease. And the larger droplets kind of fall to the floor where they then desiccate or evaporate. And of course, humidity and UV plays a huge role in that transmission. And then, of course, climate change and urbanization greatly contribute to particulate matter and other air pollutions, and exposure specifically in low and middle income countries. When we look at factors that influence indoor air quality, crowding and poor ventilation plays a huge role. There's lots of studies that have looked at public transport, schools, clinics, where there's poor ventilation, large crowding, which leads to, of course, increased exposure. And then as mentioned recently, there's vulnerable populations such as minors, which have the included risk of silicosis or silica dust exposure, and then healthcare workers who have an increased risk of exposure to TB for long periods and in poorly ventilated areas quite often. And there's been a few of these instances that have been linked to super spreader events, and this is where there are some people that just tend to be more infectious than others, and they have been termed super spreaders and are more likely to lead to larger transmission events. There's also, of course, comorbidities such as diabetes and people living with HIV who have already got compromised immune systems, which increases the risk for TB exposure, as well as being influenced by poor air quality. Then, of course, smoking, we all know, including secondhand smoke, increases risk of TB and contributes to air quality in general. And then for indoor cooking, specifically in high TB endemic countries, is a large contributor to indoor air pollution and particulate matter exposure, where biomass fuels are often used for cooking because there's no other options, and this really leads to poor air quality. So one such study, which was done in the Democratic Republic of Congo in Bukavu, enrolled TB cases, which were confirmed by the expert molecular testing or sputum smear microscopy, as well as controls. And these cases and controls were all asked to complete the IMPALA survey, which is the International Multidisciplinary Program to Address Lung Health. And this asks questions about what type of home do they have? What is the cooking situation? Do they use biomass fuels? Do they use the 3-stone cooking system, which is quite prevalent? So here you can see an image of it. It's 3 stones where biomass fuel is used at the bottom for cooking. And then a random subsample of these participants were also asked to wear a 24-hour carbon monoxide monitor. So results from the study found that about 2/3 of the households had the kitchen located inside of the main house, but only half of these had chimneys or some sort of ventilation. So this really points to the poor ventilation in many of these cases, specifically higher in cases than in controls. Again, it was found that biomass fuel was used for cooking. It was more prevalent in cases than controls, as well as high exposure in terms of time spent in the kitchen. And high exposure here was defined as more than 3 hours a day, more than twice a day, for 5 or more days a week. So the 24-hour time weighted average of personal carbon monoxide was positively associated with the odds of having pulmonary TB, and this increased to 4.2 adjusted odds ratio when only females were considered. And the same was found for time spent in the kitchen. So when they adjusted variables for the model, which included gender, age, case contact, reported secondhand smoke, type of fuel, etc., they found that exposure increased across the quintiles in terms of exposure to CO2 levels. And obviously, the higher the exposure, the higher the likelihood of having pulmonary TB. We also had a different study, which was done here at Tygerberg Hospital in Paro, which was looking at the risk of new TB infections and whether it correlates with occupancy density and air change rate in the hospitals. So this was done using carbon dioxide monitoring and incidence of TB. There were 187 healthcare workers recruited for this specifically, as we wanted to determine the risk of infection for healthcare workers in our setting. This was done by doing an interferon gamma release assay at baseline and then again in 12 months' time. Those that were IGRA negative, half of them, a subset of them, were asked to do CO2 monitoring as well, using a personalized CO2 monitor, which was worn at the waist. And this was just so that there wasn't any influence from the respiratory system. And this was worn for 1 to 3 routine work shifts, and it logs every 30 seconds. So the results from the study showed a high TB infection risk of those who were found to be IGRA negative. At baseline, 35% had converted to IGRA positive within a year. The IGRA converters experienced higher median CO2 levels, which is indicative of poor ventilation and rebreathed air. And it was also found that for each 100 parts per million increase in CO2, the odds of IGRA conversion also increased almost twofold. So what interventions and innovations can be done to address some of these? Like we said, it's not just one syndemic on its own, they all influence each other. But in terms of environmental engineering controls, improving ventilation, using HEPA filters or UV has been shown to make a great impact, as well as constant air quality monitoring. In terms of policy and behavioral measures, reducing biomass fuel use and introducing clean cooking programs is vital, as well as when designing buildings, ensuring that there's proper airflow. Mask use in high settings can reduce the concentration of TB in the air. And then, of course, occupational health regulations for mining and industry. Then in terms of diagnostics and surveillance, early detection is vital for reducing airborne load. New tools like aerosol sampling are important and is growing in popularity in research at the moment. And I'll cover some of those now, quickly brief, just to show you what it is that we are working on. So we've got the human aerosol chamber, or the HAC system, in our facility. So it's a large 950-liter drum where we ask participants to stand in and then perform various respiratory maneuvers such as breathing or coughing. This is connected to sampling ports, which are regulated via airflow meters and HEPA filters. We do CO2, humidity, and temperature monitoring, as well as particle counting. And we use various forms of sampling. So we've got SKC biosamplers here, which allows us to capture the aerosols in liquid, which can be used for molecular testing or culture. And we also use an Anderson Cascade impactor, which has agar plates and captures the TB on the agar plates in a size-dependent manner, so that you can actually grow and see whether there's viable TB being transmitted. And we use this in collaboration with the City of Cape Town to identify whether non-stigmatizing face coverings reduces infectiousness. And this is being written up currently, so hope.
Anyhow, I think it was close to the end, and it's very good that she did have time to show us some of the advanced methods that they are implementing, and that in itself is a illustration of partnership. I believe Koen van den Driesche, who's from Belgium, helped to set up that chamber and did his PhD originally on some of that work. So just an example of good collaboration across national borders. Rujana, I'm not sure if you are back with us.
Sorry, I saw I was kicked off. I'm not sure where I dropped off.
That's all right. Well, it's good. We have to wrap up, but I just want to check if there's anyone in the chat who has a question that they want to pose. There were lots of hand clapping when you were gone, and fascinating to obviously see also the tools that you have at your disposal. You cut off before you could say, and maybe you're not allowed to talk about non-stigmatizing face covers and their potential value. Do you still believe in their potential value after your study, or yeah, is you able to comment on that?
Yes, yes. Sorry, I took out the results because I didn't want to go over time. But yes, we found that the non-stigmatizing face masks were just as good at reducing the amount of TB that's obviously aerosolized, with the exception of a bandana that obviously didn't work well, and that's because it had that air, that opening at the bottom. But I must say the study cut off halfway through COVID, and then everyone was happy to wear masks. So we paused the study for a while, but we've noticed a decline in people being comfortable to wear masks yet again. So the City of Cape Town is asked us to continue on with that now.
Yeah. And these non-stigmatizing masks were really just any cloth covering apart from a bandana.
Yes, it was any cloth covering, specifically a buff that was double folded, worked really well. The double lined face masks, the cloth ones, worked really well, and also the cheaper Queen Charlotte masks, which is literally just a paper mask, also worked quite well.
I just want to check if there are any questions for any of our speakers. We have got 5 minutes for brief discussion, just to thank all our contributors again. But please feel free. I think we have all our session speakers online, so anyone that has a question for any of our speakers, if you can keep it brief, just so that we can have a few participants contributing.
Ben, I think Sassy's question was really important.
I saw, Sassy, some request for questionnaires, but Sassy, if there was another question that I missed, please, if you're able to ask that would be wonderful.
Yeah, thank you. I think it's quite neglected issue, and with the current access to internet, I think it's not very difficult to do like a short or like a quick survey to TB patient. And but the thing is, like, there are so many questionnaire to assess TB mental health, and I think it's nice if we can have a like a recommendation of what a better tool, which is not too complicated for TB patient to understand, because sometimes the question is a bit, even for me, it's difficult to understand. So it might lead to, how to say, like inappropriate result, or to something like that. So maybe if someone here have a recommendation for tools or questionnaire that easy to understand for any context, that is not too complicated, not too deep, but we can easily assess this mental health issue in Indonesia. Yeah,
Maybe that's something that Claire could speak to. Clearly, there's a lot of emphasis on developing minimal core data sets so that we can standardize data collection in some of these crucial issues, and mental health and post-TB care is one of those. But Claire may have spent some time to think about this already. And
yeah, thank you so much for the question, Sassy. So in the WHO document, they mentioned, I think they say that there's 6 that could be considered. I think probably the most commonly used are variations on the PHQ-9 or 2, whatever, which one you ever want, and then the GAD-7, and then there's also ultra short versions of that as well. I think those are probably most commonly used across different settings. I think that the sort of 2 things to say is that, yes, we need to have things that are standardized, but I also think that there's a strong argument to ensure that we're capturing contextually relevant and contextually derived concepts of what mental health means. And so generally in the work that we've been doing in Zim, particularly because we're very lucky that Dixon Chibanda has pioneered mental health in Zimbabwe and developed the tool, we've got an endogenously developed mental health screening tool, which is called the Shona Symptom Questionnaire. And one of the key concepts in that is this idea of thinking too much, which I don't think really comes across, to me at least, in many of the other sort of internationally developed screening tools, but is really important for how people in Zimbabwe conceive what it means to have poor mental health. So trying to balance a need for international standardization with contextual relevance. The other reflection I've got, having recently done a lot of work around translating a quality of life tool for use in our setting, is sort of the importance of a really robust translation and then back translation, so that we understand what the concepts really mean as we use these tools in different settings. And what we've seen from our recent work is that concepts can quite quickly evolve as we translate things multiple times. So I think those are my main things to say on that. I don't know if other people have thoughts. There's a lot of other expertise.
No, thank you, Claire. And that's clearly I suppose, a clear recognition of the need, but also a warning that we need to do this with careful consideration of doing it well and doing it in a properly contextualized fashion. I just want to ask, we've nearly run out of time, but if our colleagues from Mongolia, Basra, I'm not sure if you or any of your colleagues are still online, are able to comment on any of the your experiences about mental health in TB healthcare workers and your perceived influence that may have on their ability to adequately care for their patients.
Well, thank you for the question. The mental health of healthcare workers remains a challenge, particularly in TB in Mongolia. We have only mental health center, National Mental Health Center, and there is no program or anything really for healthcare workers in Mongolia. I think there's still a challenge, and one of our stigma assessments have shown that being a TB clinician also discriminated, and this also gives a lot of pressure on our TB clinicians. Yeah. Thanks.
Thank you. It's just good to have perspectives
Yeah.
from so many different contexts, and there's clearly a lot to learn. I have to wrap it up here because our session is finished, but just to thank everyone, the speakers, but also everyone that have stayed and contributed so constructively, and for all the very productive chat talks that I haven't been able to follow everything, but I see that there's some good pearls there. Thank you.
But this is just to set the stage for our next session. Sharing a video from Papua. This is just a short video featuring a TB survivor. The story is about a TB patient who was diagnosed with TB, and she was living in a very far away from the city. Like it took her about 6 to 12 hours travel to a district hospital, and because of this distance to her house or to hometown, like the staff, they cannot do a contact screening. But then after we identified that there are also family members suffering from TB and much worse than the current patient, I think it's also raised an issue about the importance of household contact screening, and also looking at other social condition or other social issue that might affect their adherence to TB treatment. So yeah, please enjoy the short movie, and I'll give to Basra to continue and chair the session. Thank you, Michaela.
Thanks, Hasil.
Pertama saya dapat sakit, muntah darah, baru saya batuk-batuk, batuk terus.
Maybe can you turn on
batuk baru. Mama ke rumah sakit.
Yes, the subtitles are on. Can anyone else see?
Yeah, I couldn't see it before. Okay. Thank you. Sorry.
Kasih keluar darah kotor. Keguguran. Langsung mama dapat sakit. Sakit keras. 2017 saya dapat. Kita ke ACTnet, balik lagi, ikut kapal, ambil obat. Pertama saya sendiri dengan anak-anak. Kedua lagi dengan anak-anak sendiri. Ketiga baru sama-sama dengan bapak. Baru kita balik. Cuma batuk-batuk saja. Udah biasa rasa bagus. Terus cuma batuk dengan kepala ini masih pusing-pusing. Dan saya bisa ambil obat di bawah. Nah, biasa sadar. Aprilius juga sakit. Dia sakit gara-gara dia om berangkat. Dia dapat geger otak. Dia akan berangkat janji tuh di kayak mana. Dia bilang saya tidak lama, 1 bulan. Jadi 1 bulan itu langsung dia ambil itu 2 tahun dia ambil. Langsung dia dapat sakit. Dia sakit pertama gara-gara kepala. Makan langsung kenapa dia pusing-pusing mama. Saya pusing-pusing langsung dia tidur. Dia tidur sadar baru dia main. Dia bikin begitu terus. Langsung dia ke badan jatuh. Tidak bawa ke rumah sakit. Langsung mantri dong turun. Mantri ini kontrol dan turun baru don lihat ini Aprilius langsung mantri don tangan sendiri dan turun bawa dengan ambulas dari RSUD punya. Aprilius juga minum obat. Mama su 3 bulan su 3 bulan baru Aprilius masuk pengobatan. Dokter dia tangani, mantri yang tangani. Ya mama sesak di dada, di perut, mama rasa sakit, rasa pusing, terus sekarang mama rasa pusing. Saya menghadap di dokter di Mapurjaya situ baru ke RSUD lagi. Sudah dong infus saya 3 hari baru mama keluar itu yang sesak nafas sudah hilang, perubahan, bisa cari makan di hutan, bisa mangkur, cuma batuk saja yang masih. Mama biasa rasa badan, biasa kepala ini saja, kepala ini biasa pusing, baru mama ini biasa rasa badan tidak baik, bisa rasa begitu. Terus saya bisa ambil obat, ambil obat di bawah situ, mama biasa minum, dan biasa rasa enak sedikit. Udah minum obat itu karena mama penyakit, nanti dong dapat, itu yang dong minum semua. Dorong 2 ikut minum. Dan saya minum obat baik. Pagi bangun tidur langsung kasih minum. Aprilius juga. Saya belum makan, langsung saya biasa kasih minum dorong 2 obat. Saya sudah cerita sama dorang, saya bilang, kamu pengobatan. Itu anak perempuan lagi, dong pengobatan di kampung itu. Saya bisa cerita sama dorang. Saya bilang, bangun pagi itu jangan minum kopi dulu, jangan makan pinang. Kalau makan pinang itu dari belakang. Pagi-pagi jam 5 itu kita sudah minum obat. Sebelum kita tubuh badan yang ada penyakit itu harus dibunuh pakai obat. Baru kita bisa makan, kita bisa minum. Saya biasa bilang orang begitu di kampung juga. Baru-baru kita pergi, saya bilang orang begitu. Dokter, mantri dong nasihat kita begitu di Timika. Saya adik-adik juga saya bisa bicara orang begitu. Di kampung kan dong kanker pinang banyak tuh. Itu saya bilang orang.
Thank you, Sasi. Good morning or good afternoon, everyone. Welcome to our final session on integrated screening care within the multiple syndemics of TB. And I really thanks for Sasi to organizing this powerful story of TB survivor from the Pacific, and which really brought us directly to the heart of this session, the voices and experiences of those most affected, and reminding us that TB is never just a biomedical issue, but shaped by lived experiences, social justice, and cultural context. So thanks again. I would like to introduce myself. I am Basra Tsok, site PI for the PRISM TB clinical trial. PRISM TB stands for Program for Rifampicin-Resistant Disease with Stratified Medicine for TB at the National Center for Communicable Diseases. I'm also research and innovation lead at the Mongolian Anti-TB Coalition. I also serve as a member of the scientific committees, both for the National Center for Communicable Diseases and the National Center for Public Health of Mongolia. In addition, since this year, I serve on the medical ethics monitoring committee of the Ministry of Health. Regionally, I co-chair the Asia Pacific Activist Coalition on TB, ACT-AP, and nationally, I chair ACTmen in Mongolia. And I also would like to sincerely thank the organizers for the excellent preparation and warm hospitality. With that, I would like to invite our first speaker, Professor Justin Denham, who is an infectious disease physician and medical director of the Victorian TB program of Australia. His work includes clinical and public health management of TB, as well as research in TB ethics, epidemiology, clinical medicine, and public health. He is the current chair of Australia's National TB Advisory Committee. I can just add that he visited Mongolia, hi Justin, 3 years ago, I believe, and where he facilitated ethics training for health institutions of Mongolia, the Ministry of Health, and also visited the STREAM clinical trial site, our site at the National Center for Communicable Diseases, in his capacity as a Union Ethics Committee member. So the floor is yours. Thanks, Justin.
Thanks, Basra, for that very kind introduction, and thanks to the organizers. This has been a wonderful symposium, and I'm glad to have the chance to speak. I do feel like I should start with a little bit of a confession, because I've spent quite a lot of time in the last couple of weeks trying to work out whether I had anything that was valuable enough to say about the ethics of integrated screening for tuberculosis. Now, that's not just intended to be self-deprecating, but part of the reason why ethical issues are generally interesting and important in symposia like this is some degree of dynamic tension. That is, if we've got something that is objectively good and there's no countervailing forces that would make us act or think or live differently, well, that's just what we should do. It's not controversial. It's not really worth wrestling with in that sense. Now, there might be lots of logistic or funding or advocacy barriers that have to be overcome, but in a lot of ways, they're not really the sort of ethical issues that we grapple with. And in a lot of ways, I think the whole foundation of this symposium and the various talks that we've heard is that the existence of multiple syndemics of TB in our historically siloed services, they imply that integration is optimal and powerful and should be pursued in order to support people and communities more holistically and effectively. Now, so that we don't just finish this symposium on a completely utopian view, though, saying something about the ethics of integrated TB services, I think does mean engaging with a couple of potentially awkward questions first, which is, why might integration of TB services be unethical? Are there reasons why we might moderate or temper a push towards greater integration of these services? So I have 4 themes that I want to briefly just sit with. Some of those are drawn from the broader ethics literature, but most are at some level things that myself and many of the others here on this call, I think, will have encountered directly as TB programmatic workers. So take these as reflections from practice with all of the biases that come with that. So the first thing is to say that I think it's an uncomfortable truth for those of us who are TB focused, and like me, increasingly discovering that there are critically important structural issues that need addressing: poverty, housing, food insecurity, mental health. Now, if these issues are fundamental, and arguably in a lot of cases, things that might actually be a higher priority than just the narrow provision of TB services, there is a risk that we run integrating TB services and distracting from those primary objectives. That is, if fundamentally the most important issue in a given context for a group of people may be housing or poverty, how do I find the line of when my attempts at a TB-specific response might actually be harmful by taking community or political attention or funding away from those primary issues? Second is, in some ways, the reverse of that, which is again faced by a lot of us who are coming at this from a TB-specific perspective. The integration of the elements that we've talked about here broaden TB services and our activities. And so the question of how much we can expand to include diabetes, HIV, silicosis, leprosy, malnutrition, mental health programs, smoking cessation, without damaging and diluting the provision of core TB services. How can we maintain a skilled workforce that has to do more and more, often with less and less? How do we continue to deliver excellent TB support and best outcomes for people in communities impacted by TB when TB is no longer what defines us, but it's just one thing amongst many that we do? And Manisha, thanks for the question, but no slides. I'm afraid you just have to look at me today. So the first of these 2 points, those first 2 points really relate to the provision of excellence in TB-specific services. I do think, following on from some work that Basra has done, though, and we've already alluded to here, there is a question about the way that we might actually be causing harm through the work we do if we're not careful. So, as I said, Basra's already made comment about how healthcare workers themselves experience stigma. And while we often assume that stigma comes from communities and better education will fix it, the reality is sometimes that our services themselves, because of their structure and nature, can create and reinforce stigma through our own attitudes and implicit values in how we design and run them. And so we risk the potential of introducing stigma into the management of other conditions because of how we engage with TB when we integrate TB services without thoughtful and community-driven co-design. So if we are going to integrate TB services with other programs, we need to be very careful that we're not also smuggling in that stigma and increasing risk of marginalization in that action. Finally, while data linkages and connection of services has great potential advantages and opportunities for efficiency, we are very familiar with all of the challenges that come from privacy and confidentiality, from big data and the social media magnates in our society more widely. So might integration drive connection of data and services beyond the boundaries of privacy that individuals and communities might want? What are the mechanisms that we need for individuals and communities to be comfortable and supported by our programs, rather than risk contributing to insecurities about how sensitive health data is used and how it is collected and stored? So I've tried to outline just quickly 4 potential ethical challenges or tensions that might arise in our conversations about integration of TB, screening, and service delivery. That is, of course, intended to be a little bit provocative, but it does leave us with the questions about how we move forward from this symposium. Right? How do we grapple with those tensions? I don't think these concerns are things that should stop us from pursuing integration, but they do need to keep us asking questions about how our services can be genuinely benefiting the people and communities that we serve. And this, I think, is the key for us as a service community looking to engage with these challenges. We need to acknowledge that these tensions exist and allow them to be transparent. And critically, we need to be honest enough with ourselves to recognize that some of these tensions arise or are heightened because of our egos, because of our sense of self-identification with the services we provide. And if our focus is really on genuine and holistic benefit for people and communities affected by TB, we need to find creative, structural, and systematic ways to listen to their voices to guide us in designing integrated services that really serve them. listening sounds like a very simple thing to do, but I think all of us have experienced the way that genuinely listening to people in communities can open us up to some surprising changes. For me, one of those was working with a team led by Krista Geeling, who came to operate some citizen juries with migrant communities around services for TB infection. Now, as a program director, I was interested in how they would approach community education, how they might design health promotion messages. And I really started with a plan to develop targeted screening programs for those at highest risk, because I wanted to optimize risk and benefit and develop an efficient program. The groups that we spoke to, though, pushed back unexpectedly, from me at least. And they explained to me that the more effectively we identified the highest risk people for screening, the more their communities would be affected by the perception that they could be divided into us and them. And the more reluctant their whole community would be to accept screening that might marginalize them. So they really pushed us towards much wider, or preferably universal, screening programs so that the collective experience could be prioritized in how programs were developed. Now, that's a challenge from a public health budget point of view, but doing it because it's a clear mandate from affected communities is powerful, and it's worth fighting for. Similarly, when it comes to expanding our programs and integrating our services, we can work to ensure that we are listening to community priorities and designing our programs in ways that respond to real need and values, rather than integrating just because it's in vogue. I do want to finish with a note about ego, because what I've said in this talk, that ego is part of the reason why we might avoid some elements of integration. I don't mean that to be a wholly negative thing. We all want to do things well, and ego as self-identification with our work and our role, it's a powerful driver for us as we establish services. And we don't want to throw that away. But I do want to encourage myself and you so that we can reinvent ourselves as people who are orientated towards service rather than services. That is it possible for us to identify ourselves with the real needs of the communities that we care for, rather than the specific programs that we run? We need to be able to do many things, and the synergy of being people who are able to do many things reasonably well at the same time is probably more effective than just doing any one thing perfectly. This is the malaria net problem of the so-called effective altruists. That is, after economic analyses suggested that buying malaria nets was the most cost-effective way to save a life, that the market becomes flooded with people putting all their donations into malaria net distribution, which collectively is very likely to lead to worse outcomes than a better distributed and less efficient process would have been. For me, one of the things that this seminar has highlighted is the amazing diversity of skills and passions that are found across our programs and our communities. And that diversity is a massive strength. And if we can harness it towards building services that really serve the core needs of our world, we can make a phenomenal difference and make sure that our programs are genuinely ethical. So I'll stop there, but really looking forward to hearing your voices and your questions when we reconvene with the panel later on. Thanks.
Thank you, Justin. Perfect timing. I really appreciate that. And I would like to invite our second speaker. Is Emma Smith, is an infectious disease physician and a PhD student working and living in Larrakia country. She is from Menzies School of Health Research and also works at Royal Darwin Hospital. Her research focuses on TB elimination strategies in remote Aboriginal communities in the Northern Territory. Today she will be talking about vulnerable populations, spotlight on Australian Indigenous health. Floor is yours, Emma.
Thank you so much for the introduction, and thank you for everybody who has stayed until the last session of the day. I'm going to be talking today on taking a spotlight on TB in Australian Indigenous populations. Just can I check that everybody can see my slides and hear me okay?
Yes, thank you.
Thank you. And I just want to start by acknowledging the traditional owners of the land that I'm joining you on from today. So I'm joining from Larrakia country in Darwin, but these photos are of the incredibly beautiful and culturally rich places that I get to travel to and have to pinch myself that I get to travel to as part of work and PhD life, and really just acknowledge the incredible people that I work with in those communities. And I really just want to start with this quote. I'm sure everybody is at least reading or has read John Green's new book called Everything is Tuberculosis, but he has this pretty powerful quote of nothing is so privileged as thinking history belongs in the past. And when I think about TB in Australia, this really resonates well with me. And when you really talk to people in Australia about TB, most people are extremely surprised to hear that we have any tuberculosis in Australia, let alone have ongoing kind of local transmission of TB. And of course, we know that the incidence of TB in Australia is of course extremely low. That was in great thanks to the National TB campaign, which you can see on the kind of graph on the left, where the number of cases of TB reduced dramatically due to community-wide mass X-ray screening in the 50s and 60s predominantly, and really drove the rates of TB down significantly. But unfortunately, this screening campaign used the electoral roll at a time when Aboriginal people were not eligible to vote, and so were significantly were really disadvantaged by this program, and probably accounts for why, at least some of why, we see a really different rate in non-Indigenous Australian born people who are really at elimination / pre-elimination rates, and why the First Nations Australian population are disproportionately affected. And just looking a little at remote Australia, as for people who don't know Australia, it really is a massive country with, as you can see by the kind of map at the bottom, the vast majority of the population living in the coastal regions of the East Coast, and really a very significant remote area. 15% of all First Nations people live remotely, but in the Northern Territory where I work, 80% of First Nations people live remotely. And really, our systems in Australia are not set up well to deliver care in remote communities, and there are some very significant barriers to health and well-being of Aboriginal people, including poor access to healthcare, with often requiring teams to sort of fly in and do outreach clinics. There's major food insecurity issues, crowded housing conditions, and really limited resources in health settings. So to take TB, for example, most of the clinics that I work in don't have an X-ray machine, so we're unable to do even quite simple things like chest X-rays remotely. And we know that everyone will know that South Australia experienced a cluster of cases in 2021 after having no cases in that particular region in the APY lands for a number of years. But we do also see ongoing transmission of TB, not only in the Northern Territory, but also in New South Wales and in Queensland. And what we see in the Northern Territory in particular, but I'm sure is seen elsewhere, is there's really significant diagnostic delay and late presentations, more than what you potentially would expect from a global level. So often patients presenting with very late smear positive cavitary pulmonary disease. And up in the Northern Territory, we do see a lot of miliary and disseminated TB as well. This small study in Northern Australia showed that those delays with regards to late presentation were more likely if someone had extrapulmonary TB, not unexpectedly, and health system delays in terms of diagnosis were when people were non-smokers and over the age of 45. And really, in Australia, we have very limited data on TB infection, although we know that there are high rates in some communities. So we did a recent look at one of our larger communities in the Northern Territory and collated all of the data on TB infection, and 14% of people in that community have TB infection. But actually, of the people who had actually been tested, it was 46%. And they're obviously a predefined group of people who are very likely to be contacts of other infectious cases. But I think we'd all agree that that's a pretty high number, a pretty concerningly high number. And then there's also been in the recent outbreak in the AP-YLAMs, they found around 5% of people in the community screened had TB infection. So really a high number of people with the potential to reactivate TB. And given that we're talking about syndemics of the last 3 days, we really have the combination of high rates of TB infection and a very vulnerable population for reactivation. So there are high rates of diabetes, cigarette smoking, and malnutrition. 13% of all Aboriginal Australian adults have diabetes. And in some communities that we work in, there more than 40% of adults smoke cigarettes. So this is really some of the stuff that we need to, I guess, be attempting to address as well. And I think, we still have an ongoing, very vulnerable population in terms of the amount of TB infection and the number of kind of comorbidities that would increase risk of reactivation. And so really some of what we've been trying to do in the Territory is really think about what are the considerations for a TB response, and just thinking about holistic wellbeing when it comes to remote Aboriginal Australians. Our team's been so privileged to be entered into this world and to gain some really amazing insights, and just to really understand that the connection to country is just so incredibly important, that things like traditional ways of healing, like bush medicine, are taken into consideration when we're managing patients, not just with TB, but of course other conditions. The importance of family and kinship is just so strong and incredible. And there's also very significant spirituality considerations and cultural obligations that all really need to be taken into consideration when you're thinking about how you respond to the ongoing kind of TB transmission in remote communities. We know accessibility is a really big problem. Care is often delivered in hospitals or clinics and most of those settings are just not culturally safe environments for patients. We don't have a lot of ability to, with the current way things are, is to have more services available really remotely, actually in the community. And something that I've learned throughout my PhD and doing, sitting down and listening to stories is the understanding of people, of Aboriginal people around TB is really limited. There are many, many, many Aboriginal languages, and there's such a lack of resource in language. I can really only think of South Australia's resources that are in local language. And I just included this quote from one of the Aboriginal health practitioners that I interviewed as part of my PhD, and to say most people don't know anything about TB, so they wouldn't have any shame at all. And it kind of disturbed me, this notion of stigma coming from knowledge, and that, you know, really the understanding is so limited that people would not feel shame or stigma around having TB because people just don't have a good enough understanding of what it means or to have TB. And so what are some of the things that we've been doing? As I said, we've been really trying to, as Justin alluded to, just try and sit and listen and learn through people's lived experience. It's been an incredible journey of just understanding people's journey. We've also been developing in-language resources, so in the form of story cards and videos. We've managed to gain access to rifampicin through the Global Drug Facility, and so we've been able to now give TB preventive treatment more readily and easily in remote communities. We have an amazing team who've been training community health workers to be treatment supporters, but also to administer medications and have a really good understanding of TB, and that's really changed the scope of treating TB infection for us. And really just trying to think of ways where we can deliver care at the household, like for what reason do we really need to bring people into clinic? We've been really privileged to receive some philanthropic funds for a portable mobile X-ray machine, which has just been game-changing. And in the communities, people are so amenable to having X-rays done just under the porch at their household. And I really, really appreciate when care is taken away from clinic or hospitals and delivered with family, on country, at home. And so we have been getting a lot of successes from really trying to take it right back to kind of basic, like, household care, which most stuff for TB can really be done quite easily once you have a portable X-ray machine. So that's the end of my talk. I just included pictures of our incredible core team, and Will on the right of that picture decided that we must be called the TB Warriors. But this is really the amazing team that I work with, and Dr. Chris Lowbridge is leading this work and has been an incredible mentor and does a lot of work behind the scenes. And just an extra shout out to Nikita, who very bravely told her story and shared all with you on Wednesday. Thanks.
Oh, thank you. Thank you, Emma, and thank you too. And this comes to the end of our session, and I would like to thank all the speakers and all of you who stayed with us through this final session. Just to summarize, the survivor video was very powerful video of a powerful lived experience, showing that TB care is never just the diagnosis and the treatment, but it reflects dignity, recovery, and the equity. And survivors, particularly like the survivors' voices, it really helps us to push us from purely biomedical, medical policies to people-centered ones. We were also reminded that integration brings responsibility, particularly ethics issues, and ethics must guide us in protecting communities and benefiting them. And finally, the MS talk, the spotlight on Indigenous health, also showed us that TB services must be culturally safe and community-led. And thank you all. Please carry on your questions and reflections forward into the panel discussion that follows. And thank you once again. Thank you.
Great. Thanks very much, Basra, and thanks again to all of the speakers. So my name's Chris Lowbridge, and I'll be facilitating the panel discussion now. So I'm normally based in Australia between Darwin and New South Wales, but I'm actually joining the meeting today from the ancestral homelands of the Anishinaabe and the birthplace of the Red River Métis Nation in Winnipeg, Canada. And I'm very sort of grateful to be a guest on this country and pay my respect to the elders and ancestors of this land that I'm on at the moment. By way of background, I'm a senior research fellow and the TB research program lead at Menzies School of Health Research in Darwin, in Australia. Our program of research is primarily based around implementation and epidemiological research. We have projects in Indonesia, Timor-Leste, and in Northern Australia. And we've got particular interests in TB prevention and case finding and First Nations health. And yeah, you've heard from a couple of my colleagues, Nikita, Joshua on day one, and Emma, who are part of our team at Menzies. So in this session, we'll have a panel discussion, which I'll invite all of today's speakers to participate in. Hopefully we've got most of them still online. I think we've got around a bit under half an hour available for discussion, and I'd welcome everybody to either post a question in the chat, or you can also just raise your hand and come off mute to ask your question. But maybe perhaps I'll start with a first question. And perhaps, I guess this might be first directed towards Justin, but for all of our panel members, feel free to jump in. I think there are comments from a couple of people, Gail and others in the chat, sort of just commenting a bit on some of the challenges and risks with integrating TB care. And I think that we do often see sometimes there's a tension between priorities of our patients and communities, and priorities and I guess the structure of the health systems that we work in. And I guess the question is any sort of comments on how we address that tension and I guess sort of advocate for the preferences and priorities of our patients and communities that we serve in terms of how the health system is structured to respond to those.
Yeah, look, it's a great and a huge question, and I know that it's one that I hope that's one that other people on this call are going to come in on, because I think one of the really key ways that we respond to that question is by recognizing that we all have a variety of different strengths and backgrounds and training, and it's synergy of these things that come together. For people like me who are within a TB program that is funded as a TB program, then I think we need to work to push against the edges of that in ways that are important to the communities that we serve. And so I think a great example is work that Krista Watts is doing at the moment, who's on this call, who's looking in an integrated way to embed financial impact and the other well, Krista, I'm going to get you to come in and say something about this, but really looking at embedding work on the systematic impact of financial and housing stress and so forth that goes along with TB. So Krista, if you're still online, do you want to make a comment about that? Because I think that's a great example of how we might integrate those things. And if Krista is not in a position to speak, Krista might not be in a position to speak, so I'll just say that on her behalf. But I think that there'll be a lot of different examples that we can use to build bridges out of our historically siloed programs in ways that collaborate with people who do have that expertise. That's right, Krista. I was just talking a little bit about the financials. I'm not sure if you heard that, but feel very free to jump in.
Hi,
hey,
sorry, I
Krista.
just had to change location. Unfortunately, I didn't hear it, Justin. I trust that you were very eloquent.
That's right. Well, I hope people thought that. But would you like to say, a few words about the work that you're doing? Because we were just talking about ways that we can come from siloed programs, bridging into areas that might be in some ways historically outside of our remit, but really reflect sort of priorities that we see for the communities, like the work in financial impact that you're getting underway.
Oh, I wish I had a bit more context, Justin. And everyone, thank you for the opportunity. So I guess I'm really hoping to bridge a lot of the work that we've heard from people like Collins and Claire in the recent 3 sessions. And I'm hopeful that in understanding the capacities that people have to respond to their circumstances and the prevalence of shocks and challenges in relation to that, to socioeconomic factors, so particularly costs and access to healthcare, we can start to think about how and why some people and households cope or appear to cope better than others, and what their access trajectories are. So I'll be wanting to understand what their capacities and their ability to turn those capacities into something functional really are. So that's where I'm sitting and wanting to look at. And wanting to do that to respect the context and the really rich diversity of the communities that we work with here in Australia. I think we calculated some 156 dialects and linguistic groups, and then even more cultural diversity in amongst that in terms of faith and faith practices. So hoping to understand that more richly and think about how to link that and advocate through pathways for access. I'm hoping I've kind of hit the question there, but feel free to link back to me if anyone would like to talk about that further.
No, thanks, Krista. And for me, I think that's, a great example where we've got Krista's phenomenal social work background embedded within a TB program and trying to provide space for expanding into these other important services.
Thanks, Krista, and thanks, Justin. Perhaps we'll go to Michaela. You've posted a question in the chat for Emma. Michaela, do you want to
Oh, sure. Yes. Emma, I was just curious. You mentioned, or you said the phrase that the idea of knowledge as stigma was something that you were very uncomfortable with. And I was curious if you could just expand on that, what you mean by that. And yeah, thank you.
Yeah, thanks, Michaela. Yeah, it's something that sat quite uncomfortably with me, when looking through a lot of the stories that I've listened to, and it just sort of made me worry that maybe some of the information that we give people when we give knowledge, because people obviously naturally will get knowledge about TB from us as health professionals, that then that knowledge of knowing what, about TB transmission and can then lead to people then being stigmatized, because that sort of knowledge of then how it's transmitted and the association with that being like a source of stigma, and the potential of people not feeling any shame because they just don't know anything about it at all. And it just, yeah, go on, sorry.
Would you contrast that to kind of someone finding out they have the flu, and really not feeling a deep sense of shame? if you don't really understand, but that if there is something about the way that we communicate TB counseling that makes people, yeah, is that what you're getting at? Just trying to make sure I'm understanding.
I feel like if we gave the right information and people had the right knowledge, there may not be a need for stigma. But it was that even this like health practitioner was saying, well, and we then went on to kind of discuss rheumatic heart disease and scabies, for example. And, you know, now that people are more aware of scabies and skin sores and what causes those, like people are being really stigmatized, like around you know, not having a clean house or you know, and so this real sense of, you know, sometimes the way that we can think that we're empowering by giving knowledge can actually then have this like repercussion of people being stigmatized. And I think we just have to be really like cautious of that in the language that we use when we are counseling people, because I don't think it would necessarily be for, I think TB is one of those sensitive conditions. Scabies, skin sores, rheumatic heart disease is another one of those conditions that is sort of has this intrinsic link with poverty and social deprivation. And I think that's the difference. But it was a very concerning notion to me that the knowledge that we give people enables them to then be stigmatized.
Thanks, Emma. Akshita, I see you've got your hand raised. Do you want to go ahead?
Hi, and I really liked what you said actually, and I just wanted to add like some of my experience in context. So I'm a microbiologist from India, so I did diagnostic clinical microbiology there, and then I did my PhD, and now I'm working in Germany. But the way you said it is really correct, and I don't know if it's your experience as well working in like different communities, but basically in India the way it is that if you don't say it, it's not there. So for example, if you're given like a cancer diagnosis or you're given a tuberculosis diagnosis, they would rather not talk about it, because if you don't talk about it, it doesn't exist. And it's that in that way, just the way you said it was so correct. Like, indeed, it's you assume that the knowledge would be like helpful and it would be powerful to like understand. But I have really noticed, like, and I'm going to say this across socioeconomic stratas, like even in like extremely privileged and well-to-do families, we'll kind of not say someone has died. You'll say, you know, they passed or they expired, and you kind of use like different terms and words for it. And it's a really strange thing. And I'm really glad we're talking about it, because it's genuinely there. And it's the reason why people are like, oh, I'd just rather not know, I'd rather not listen. So yeah.
Yeah, I would say we definitely experience similar things. For example, the word cancer is almost never used in community. Everybody says the C word. Like it's just never, that word is never sort of
Yeah, I just
spoken.
never say it. Yeah.
Thanks for sharing.
Thank you so much. It was such a great talk, such a great panel, really.
Right. Maybe if I can jump in with another question, again for Emma. And I think, Emma, you highlighted some of the, I guess, historical context in terms of the experience of First Nations people in Australia, and their, I guess, experience of, I guess, being excluded from TB screening and care in the past. And I just wanted to pick up a little bit on that, and I guess the topic of trust within the community. And do you want to, I guess, just comment? You've spoken to a lot of people who have had TB in remote communities in the top end, and I'm just interested if you want to share some comments on, I guess, experience with the health system and trust in health services, or you know, traditional or other sort of, I guess, health or care seeking that we see in communities?
Yeah, thanks, Chris. I mean, there's no kind of nice way to put it. There is a really inherent distrust of the health service, like in general, I would say. And that's obviously bore out of a lot of different historical things, including exclusion and including things like the intervention. And there is a very significant barrier there for absolute certain. And Nikita and I talked about this. Sorry, she's just sitting here behind me. We talked about this at great length on Wednesday, actually, around people even kind of having concerns around Ballender people or Caucasian people, like even touching them, like in clinic, like that and that being potentially even a something that is just really not okay and not acceptable. And so when you're trying to do a Western model of care and that's kind of the reality, it's really challenging. What I think we've really noticed, Chris, and what definitely seems to help is having other Aboriginal people working at clinic. That just is a massive step to breaking down like barriers, and we've seen it multiple times with Nikita now, with peer support as well. So I think that can really help to bridge the trust gap. And I think there's, TB is so challenging from a trust point of view because you see the patient for the first time with a mask on and they don't see your face. And a lot of people have talked to me about that notion of like this, I must be so diseased, like that they are putting on a mask to like come and speak to me. And I think that really adds to the distrust. And Nikita sort of described this scenario where I sort of came into her room and took my mask off because she was past the point of needing isolation. But she said it was really strong, like a strong kind of message to her that she could trust me, even in that simple movement of just taking the mask off. And so, yeah, I think there's a lot of like small things we can do, I think, but it's obviously there's all this historical context as well. In terms of, I guess, other practices like traditionally that we very often see is that patients will have gone to a witch doctor or a traditional healer before coming to the hospital. There's a real notion of black magic being the cause of disease. But often when I've talked with people can, there is ways of kind of integrating those two belief systems together. And I don't think that the traditional kind of ways and the traditional, healers and witch doctors need to are a barrier necessarily. I think we have to make our service more accessible for people rather than I don't think that practice is a barrier at all, actually, to coming. People very much want a kind of integrated approach. They want to do all the things that will give them good well-being. So people often describe, well, I want faith, I want bush medicine, I want to see the traditional healer, and I also am quite happy to take the Ballender medicine that the doctors think I should take. So yeah, I don't necessarily think they're the barriers. I think our lack of accessibility is probably the barrier mainly.
Michaela, you've got another question. Do you want to go ahead and ask that?
I'm sorry for being so nosy. So I'm just curious about, Justin, you mentioned that when you went to the kind of vulnerable communities that you wanted to, I guess, quote unquote, target for screening, and they said that this would kind of marginalize them even more by being identifiable. And that active case finding or wider case finding was a bit of a proposed solution. I'm curious about the fact that we really only do see extremely high uptake of community-wide interventions in controlled trial settings, and that often the people who are not being reached are in fact the ones that you would most want to reach. And so I guess I'm just wondering about how we retain credibility as researchers trying to care for and improve access to care for those kind of diverse and marginalized communities, when we also don't have loud voices in addressing kind of the structural changes that mean that they're always on the margins. So just, yeah, curious about the ethics of that, and like whether or not all TB researchers must necessarily also be advocates, or what is the balance there? Thanks, Justin.
Yeah, look, it's a great question. We could talk a lot about that, Michaela. And I'll be really interested, Sissy, in some of your reflections about this in the Indonesian context as well, too. Because, I think there is a sense in which all of us are here as advocates in some ways. We're all in positions where we can see the things that would be impactful in our own areas to provide, but we also have this sort of laterality of contact with things beyond us that are not necessarily in our spheres of expertise, but we can see their value and we want to champion them and lend our voice to that. So I think that really resonates and makes sense. And I do think that even within the TB community, I'm seeing interesting and creative ways to come at this differently and impactfully. And so again, Ceci, you might want to say something about this, but I've been really interested to see a number of great pieces of work coming out of Indonesia, looking at broader community neighborhood-based screening for TB rather than some of our traditional models of contact tracing. Now, I think to my reading as an outsider there, some of the value of that is going to come from a different structural approach and different effectiveness. But some of it is also going to come from the more communitarian ways that those programs operate. I think that there's real ways for us to be challenged about how we most effectively provide our services by what we're hearing from communities, as well as just for the knowledge we gain as researchers. So yeah, Sasi or others, do you want to comment about how these sorts of approaches in your own contexts work?
Yeah, I think there's a advantage and the disadvantage of this approach. As we know, in Indonesia now, we have a new program called free health screening for every individuals in Indonesia, and just recently this system already linked with TB. So like this morning we discussed with my colleagues in Timika that they have notification that the free health screening program has identified several new TB suspects and that they have to follow up. So I think this is the advantage of this approach. But another thing is, as we know, there are a lot of new projects targeting integrated health screening for TB, measuring blood pressure, blood glucose level, etc. But the problem is in my opinion, there is no established system to ensure that this patient get care, that they will follow up, that they have if they're found with diabetes, then they can also following the treatment, not only TB. So how to ensure that we have enough resources to ensure that all patients receive the care, appropriate care, and ensuring that we have enough logistics to do all of this screening. I think this is also another ethical issue, because this is not, I think it's unethical if we do the screening but then we don't follow up with the result. And also another thing that we need to be more prepared is like people have the right to refuse. So they have we cannot force this screening. They have the right to refuse, but then considering culture and social norms, like what is the best approach so they can be more acceptable with our intervention. Yeah. Thank you.
If not, then once again, big thanks to all of our panel members and speakers from all of the sessions today. It's been a really interesting program and really, I guess, highlights the immense complexity in dealing with these multiple syndemics of TB, and we've heard some really interesting sort of thoughts and insights on how we might consider better integrating TB care. And so also just to finally say a very big thanks to Michaela Coleman for organising all of this, and perhaps we can all give her a round of applause. It's been a fantastic 3 days workshop and a lot of effort by Michaela behind the scenes to organise it. So big thanks, Michaela.